billing in your organization. And then we moved into some more specific compliance topics like price transparency and those types of things. So this is just some other things to think about when building out your compliance program and some things to focus on.
And Rachel, it looks like you are now the co-host. I believe you should have that capacity.
Okay, great. Okay, so I'm going to do this and then I'm going to. So hopefully you're seeing a presentation right now.
Yes.
Okay, wonderful. Okay, so this is just our intro slide here. Doesn't really give us a whole lot of information, but this was around, like I said, building off of some of the other, I guess, compliance related topics that we've talked about over the last couple of months. And so today we're going to cover telehealth services. That's a service that a lot of our, especially our rural organizations, tend to provide and have been involved with over the last couple of years. There's been a lot of movement around telehealth ever since COVID. So we're just going to revisit where things stand today. And then we'll talk through preventive exams and annual wellness visits. This is another issue that we find causes some confusion, mainly for providers on some levels, and so it's a educational awareness topic. And then facility emergency department level billing. We'll get into some specifics around things to look for when it comes to that code assignment. And then some billing and revenue cycle management considerations when it comes to outsourcing and some pros and cons when it comes to in-house versus outsourcing. And we know that this is a big issue for a lot of organizations, especially in our rural communities when we're looking for resources and looking for staffing. And then we'll cover specifically some financial assistance policy compliance components. So it's all over the map a little bit on this one, but wanted to fit in a couple of different types of billing and coding related topics that tend to be more of that hot topics or scrutiny, if you will, from payers as well as internally. So navigating the provision of telehealth services. So the first thing I'll mention, and this is kind of a mouthful, but the full year continuing appropriations and extension act of 2025 is really what we're looking to at this point in time. That also coincides with an April MedLearn Matters article that came out, as well as an April FAQ that CMS published on their website. All three of these regulatory documents speak to a date of September 30th, 2025. So that's really the main thing that we'll be talking about when it comes to telehealth. So of course, prior to the waivers that went into effect back in 2020, telehealth services were limited to beneficiaries in rural areas, and they had to be physically present in specified facilities to receive that telehealth service. Again, the waivers really kind of did away with those regulatory requirements. And we've been able to operate with a lot of flexibility over the last couple of years. And now we do have some information that really kind of puts more of an end date to some of this, and that end date being September 30th, which is really not that far away. So when it comes to RHCs and FQHCs, one thing I do want to mention is this distance site provision. And the distance site that provides for non-behavioral health services. So these would be medical visits, medical services furnished through that interactive telecommunications technology. That can still be reported under HCPCS codes G 2025, but through September 30th. And I've listed the exact web link here to that April MLN that's posted on the CMS website. This is really kind of a step-by-step document that lays it out pretty clearly on what we can do and what we cannot do up until September 30th, and then what is going to change and take place as of October 1st. So the way that the document is laid out is they actually have it highlighted in red, those things that are going to change as of October 1st. So I would look to this document. I would go ahead and copy this web link, and you'll get a copy of these slides. So you'll have this web link. And I would take that document and comb through it. So if you're providing telehealth services, then this would be your guide that you would want to utilize going forward in another about month and a half is pretty much all we have here. So, oh, sorry, I didn't mean to advance that quite yet. But anyway, I wanted to mention that starting October 1st, for those non-behavioral health or non-mental health visits, that originating site requirement and geographic location restriction is going to come back into place. So basically, we're just reverting back to the way things were before COVID, essentially. And then for behavioral health and mental health telehealth, all patients can continue to get their telehealth wherever they're located. There's no originating site requirement. There's no geographic location restrictions. The patient's home is permissible as an originating site. So just wanted to make that clear from this MLM perspective, and it's spelled out pretty clearly in that document. So again, going back to this full year continuing appropriations and extension act, the in-person visit requirements are delayed until October 1st. However, for RHCs and FQHCs, that in-person visit requirement is extended through January 1st of 2026. So if you're providing telehealth in the RHC or if you're an FQHC, this is extended to January 1st. So this is really the only date that's different than that September 30th date. That will be a recurring theme when it comes to telehealth visits. So this would really be the only exception to that to those dates. And this is regarding the in-person visit requirements. So FQHCs and RHCs have that transition timeline extended. And again, it's different than that September 30th date that's noted elsewhere in the documents. So when it comes to audio only and telehealth, there was a physician fee schedule final rule from 2025 that revised the definition of audio only. And I have that here listed verbatim from that 2025 rule. And the full year continuing appropriations and extensions act essentially I, copies or reiterates the definition or basically adopts that definition that's from the PFS 2025. So they're aligned in the definition of audio only. And so here, really, nothing's changed with what you've been doing since the physician fee schedule came out a year ago. So nothing has changed. They're just clarifying that they're following the same definition. So G 2025 would be the code that you would assign and report for those audio only visits. And then for Medicare and the RHC in the FQHCs, you're going to want to use the modifier FQ for those audio only visits. So that's what's going to tell Medicare that this telehealth visit was audio only. So that's the purpose of that modifier. In addition, the telehealth list has the designation between provisional and permanent for their HCPCS codes and CPT codes that they've identified for telehealth services. Basically, what they're saying is that these provisional codes are continuing to be reviewed from a utilization perspective as well as a needs perspective, but they're currently available to be utilized for telehealth during this time, during this provisional status. So this would be a good list to continue watching. I would expect that we're probably going to see some changes around this list, I would say within the next month or so, simply because in November, the AMA is going to be updating their CPT codes for fiscal year 26 or for calendar year 26, effective January 1st. And a lot of times, CMS at that time will also make the decision on if they're going to adopt a CPT code or if they're going to remain with their HCPCS codes, like a G code, for example, as their approved code for use for Medicare patients. So that's oftentimes the time that we see some of these decisions being made when it comes to these codes. And again, this is actually from last year, as of January 1st of 2025, that these are CPT codes that are valid CPT codes in the CPT book. However, I do have a bolded statement here that CMS did not see the need to recognize these above codes because they felt that their code also basically already reflects what they're currently performing. And so these codes would not be used for Medicare patients, but you might find that your commercial payers are asking for these codes. So this is just something to be aware of. And these codes went into effect January 1st of 25. And again, the AMA will come out in November of this year, so November of 25 in anticipation for January 1st of 26 with any new potential codes. And it's always possible that Medicare may change its mind and they might decide to adopt and pay on some of these CPT codes. So when you have your annual code update as part of your charge master review process, perhaps, these are some of the things to watch for to see what are the new CPT codes, but what is Medicare recognizing as far as those new CPT codes are concerned. This is one CPT code that also was effective as of January 1st of 2025, so that we've just had this in place for 1 year. And this is regarding this brief synchronous communication technology service. So if this is something that your organization is utilizing, then you would want to pay attention to this slide. CMS did go ahead and decide to adopt CPT 98016, and it's applicable to Medicare telehealth services. So this is an example of where they had the G code in place and decided to go ahead with the AMA's CPT code and utilize that code instead. Again, this is from the beginning of this past year. So there might be some new codes. Oh, sorry about that. There might be some new codes that come out in November that will impact some of this telehealth, some of these telehealth approvals. And this is just a quick reminder of eligible providers. This hasn't changed, and so this is still the same list from the past several years on who's eligible to provide telehealth services. And one thing I'll note too is that I know that there was quite a bit of discussion around physical therapy, occupational therapy, and speech therapy, as well as those services that might be supplied by a registered dietitian, like the diabetic self-management training and medical nutrition training. So this is something that is also going to change as of September 30th. So please be aware of this date if these providers are providing telehealth services currently. And then just a reminder on the originating site, this hasn't changed either. It's still the Q code Q30114. And the calendar year payment for this code was 3101. And we would expect to see a new payment amount that will be in place for calendar year 2026. But I just wanted to include this information for reference purposes. Okay, so now we'll get into preventive exams and annual wellness visits. And it might be that this is something that your providers have a very clear understanding with. I know that when we're doing some chart reviews and working with providers, sometimes there's a little bit of frustration, if you will, around some of these types of codes. And it's really around, I think, messaging, not only with the providers, but also with the patients. So they have a clear understanding of what a preventive visit is versus what an annual wellness visit is. And I think this is a really good chart that just outlines the differences between these various visits. So this includes the Welcome to Medicare visit, which is the G0402, and then the initial annual wellness visit and the subsequent annual wellness visit. So we are able to perform that Welcome to Medicare visit once a lifetime. And the initial AWV is also only performed once a lifetime. But that subsequent AWV we would expect to see on an annual basis. So there are 3 different codes for Medicare purposes to utilize for these types of visits. And the eligibility requirements are outlined here as well. And we want to see that Welcome to Medicare visit take place within the first 12 months of when that individual is enrolled in Medicare Part B. So that's the time frame that we would want to see that happen. And again, there's some physical exam components that are incorporated into each one of these, and they're a little bit different because the Welcome to Medicare is going to have a little bit of a different approach than the annual wellness visits. And then there's also some screening that can take place during that Welcome to Medicare visit, like the EKG, for example. So there's just some good things in this chart that are a little bit helpful in determining the difference between the Welcome to Medicare visit versus the AWV. So the background, I guess, or the intention around that Welcome to Medicare visit or that initial preventive physical exam is they're wanting to promote good health through disease prevention. And that's why CMS will pay for one of these initially when they are covered under their Part B. And the practitioners that can provide this are physicians, clinical nurse specialists, nurse practitioners, and physician assistants. But you can utilize clinical staff within the clinic to obtain additional information. So some of that might be that patient consent form. They can facilitate the screening questionnaires and the collection of data that can record vital signs, and they can provide patient education and, of course, coordinate all the follow-up visits and appointments and kind of keep that patient on that timeline. So the service elements are best described as from the clinical personnel or auxiliary personnel would be these things that are within their scope of practice and are under the supervision of that billing provider. So we do want to have that correlation between whoever that clinical staff person is working with that provider as well as working within their scope of practice. So some other things within that visit might include that health questionnaire that's completed, medical history, family history, a current medication list, any other providers or suppliers that patient might be working with. Any patient self-reported information can be collected by that clinical staff or auxiliary personnel. And this just helps with the complete and efficient collection of data because there is quite a bit of information that is being asked of the patient during these types of visits. So that's why it is important to lean on additional staff in these types of cases. So when we get into the annual wellness visit, that's when we're performing that health risk assessment that called the HRA. And again, we can utilize other staff within the clinic to help facilitate the filling out of the health risk assessment, ensuring that it's completed, establishing that medical and family history. Again, it's really similar to a lot of the information that we can gather during that Welcome to Medicare visit. In addition to, there's some screening components. There's some risk factors for depression that can be collected, functional ability, and then establishing that screening schedule for the next 5 to 10 years. I know that sounds pretty extensive to establish that so far out, but if it can be established even within the next couple of years, that can just help keep that patient on track with the various screenings that they're eligible to receive and to receive those in a timely manner. And then also, it's the ability to furnish personalized health advice and give those appropriate referrals to other health education or counseling programs that might be established. And it's also to collect that list of risk factors and conditions that may be primary or secondary and interventions that might be recommended along the way for those patients. So again, it's really going back to the prevention for the patients well-being and prevention of illnesses going forward and trying to establish what those risks might be and how to mitigate those with the patient's care. This also includes the option for advanced care planning services to be a component of the annual wellness visit. So the subsequent AWV contains essentially the same components as the initial, but the goal has changed a little bit. So the goal now is to review and update those components that may have changed rather than establishing them from the beginning. So it really should be taking that initial document from the initial AWV and then updating it as appropriate and as necessary based on what's changed with that patient from the prior year. One of the things that, and this is more coming from the ACO, and they've, of course, encouraged providers to complete these AWVs and to establish that 5 to 10 year care plan, generating through that health risk assessment portion of the AWV. So there's been a bit of a driving force behind this from the ACOs, as you can see. And one of the things that they've stated is that if the provider is spending significant time with a patient during that AWV, ordering labs and tests, for those types of things, then they essentially feel like that's missing the point of the AWV visit. And so they really encourage that HRA is completed and that is providing meaningful information for the provider so that they can have a conversation with the patient and have that visit be more meaningful and focused around that patient's care versus having to go through the mechanics of ordering tests and updating information in the EHR and those types of things. So it's really an opportunity for the provider and the patient to have a in-depth conversation about their risks, their care, what services they might be qualified for and that can be ordered for that patient, and other supporting services that they might be eligible for. And again, advanced care planning might be part of this conversation, depending on the answers from that HRA. So these are just some of the things to reiterate with the providers and also share this information from an appropriate perspective with the patients so that they come into that visit with an awareness and an understanding of what the purpose of that visit might be. And then this is just these rates are going to change, but this is what they were this year for the preventive visit versus the AWV visits. So you can just kind of see how those compare with your traditional E&M codes as well. So I do want to talk about facility ED E&M leveling a little bit here. So if you've ever gone through a charge master review, this is one of the things that we do end up talking about is how do you arrive at the facility ED E&M level? And just a little background information. So when APCs became effective back in, I want to say it was 2000, 2001. This was when we suddenly had the ability to charge a facility level for our ED visits. And that's really what prompted this leveling to take place. And although you're probably not, if you're a critical access hospital, you're not paid on APCs. However, we would still want to collect this charge from a facility perspective. So what we've built in our charge masters is typically a 99281 to 99285 CPT code range. And we have different prices associated with these. They're mapped to a revenue code 450. And what CMS did back in 2000, 2001, and they really haven't deviated from this at all in all these years, is they've allowed facilities to incorporate their own leveling structure to determine what that level should be from the emergency department perspective. So then that really created this I guess kind of a gray area for organizations because yes, that's great. We're allowed to create our own leveling tool, but how do we know that it's compliant and who establishes that? What are the parameters? So I know that we've all been living in this world for quite some time, but it did create a lot of anxiety at the beginning to understand what we should be including in a leveling tool versus what we shouldn't, and what should that look like. The most common tends to be a point related system where we might have points developed for the nurse collecting vital signs or various other nursing interventions that might take place in the emergency department, such as um, uh, ordering x-rays and lab work and those types of things. So there's a number of nursing interventions, and the goal around the ED E&M leveling system is to capture facility resources, nursing, of course, being a facility resource. And the leveling tool does not need to correlate or correspond whatsoever with what the provider, what the ED physician is selecting for their level. However, we would also expect to see a little bit of a connection between maybe the bell curve or the distribution of the levels. So, for example, if we see that the facility leveling tends to be more of a level 4 or a level 5 for distribution, but we see that our providers are always at a level 3. That might indicate maybe some tweaking needs to be done in the tool, or maybe there's an educational opportunity that we could we could address with the providers. So, kind of a couple different ways to look at that. Well, what's happened recently with facility ED leveling is that we now have sophisticated electronic medical records that might have a built-in leveling tool. And there's an algorithm that's built within the system. And so when nursing documents various interventions that they're performing for the patient, it's calculating a level behind the scenes. And we, as the hospital, we might not always know exactly what that leveling tool looks like. And this creates a bit of a compliance conundrum for us because we have our name on that claim form, and we're essentially saying that level 4, level 5, whatever it is the appropriate level. Yet we might not know exactly what is behind that level in its calculation. And some of this information is proprietary. So sometimes we're not able to easily get our hands on what that algorithm or what that tool looks like and how it's built in the system. If you're an affiliate of a larger organization's EHR, so if you're an affiliate for an Epic or a Cerner, that gives you even less visibility typically on what is happening with the ED leveling piece. And the reason I bring this all up is because there's been some significant auditing being performed around ED leveling. So this is just an example of something that happened at a Colorado facility. This is last year. Um, Essentially, they were found to be automatically assigning a 99285, which is the highest level of that ED visit. And these were claims that were submitted from 2017 to 2021. So they went back pretty far in looking at these. And really what happened is that that organization didn't necessarily know what was driving that 99285 level. That doesn't necessarily mean that they shouldn't have known. It was their bill and this is their organization. So it is their responsibility to know and understand what's driving that facility leveling assignment. So this is getting some organizations into some trouble simply because we don't always know what's happening behind the scenes. So, another way to put this is that that facility EMR may have built like a checklist where they're assigning a level based on the number of vital signs that were checked or the total number of hours that the patient was present in the ED. These things may not necessarily correlate to the severity of the patient's condition, and this is where we run into some trouble with these facility tools. So we want to ensure that medical necessity for the visit is met, and we're not just counting things like hours or number of vital sign checks and those types of things. So in this case, the United States alleged that this facility knew that its automated tool was associating the monitoring of vital signs, and it didn't really satisfy the requirements from a medical necessity perspective and accurately reflecting the resources used by the hospital, by the facility. And that's what should drive these levels is facility resources. And I know that number of vital signs and time spent in the ED is a resource, but it also does need to connect with the patient's condition and the acuity of the patient as well. So there's some other factors that need to be considered. So I would highly encourage the organization, if you don't know what your tool setup is, to obtain that. And here's some other things that, considering from a compliance perspective as well, is to conduct periodic reviews of facilities that are that using your unique point system. So what I mean by that is it could even be a sample of just 5 records in a particular quarter and take a look at what did we establish as our methodology, or what is the algorithm that's in place, and then what does the documentation state that corresponds back to that tool that we utilized. So these would just be things that, like, do we have documentation every time that the vital sign portion was given points for, those types of things. And keeping in mind that there is no national standard, so there isn't necessarily a right or a wrong unless we're really not able to establish some sort of connection between the patient's acuity and medical necessity with what that level is. And really, the ones that we want to be most concerned about are those higher levels, of course. So that's always going to be the focus of CMS and the OIG. And another thing is, if you have any pushback on obtaining what some organizations or what some vendors might say is proprietary information, I would really encourage you from a compliance perspective to push back and indicate this is our name on this claim form. These levels are going out with essentially our blessing. We're saying as an organization that this is correct. And if we don't even know how it's calculated, then that leaves us at risk. And we don't want to, of course, we don't want to be at risk. So this is one of the things that you can talk through with those organizations that might have this housed within the EHR and consider it proprietary information. So again, this just speaks back to we need to understand how this is being calculated. If your organization is an affiliate of a larger systems EHR, this does create a level of complexity, um, especially if you're trying to customize anything within that algorithm. And I think that it goes without saying that a small critical access hospital is going to have a different patient population or maybe a different demographic and different types of patients walking in the door than maybe a um, urban health system hospital in the center of a large city. And that doesn't mean that the facility calculator would be drastically different, but there might be some changes and some things that you would want to incorporate into your calculator that maybe would not be necessary for them and vice versa. So anytime that you have an option to customize it to fit your needs, I highly encourage that. And then also conduct an annual utilization analysis. And this is just to see what that distribution looks like from level one all the way through level five. You would tend to expect a peak at the three and four. Maybe four and three are the most highly utilized. It just really depends on how your point system is developed and the types of patients that you see on a regular basis. But this is something to think about from a utilization perspective. If you make any changes to your tool, or let's say that the mothership, if you will, makes a change to the algorithm, hopefully they're communicating that with you. But once you implement that change, give it maybe a couple of months and then run some utilization analysis numbers again, because if you see a large shift in what that level or the highest utilization level is showing you. For example, if you were threes and fours and then now your highest utilization is a level five, that would be a cause for concern. That would be something that you would want to dig in a little bit deeper and see, well, why are all of our visits moving to a level five? One other thing I want to mention, and this is more from the payer side of things, but it can be an indicator of a compliance issue, is if we're reviewing our remittance advices and we're looking to see if we are getting paid appropriately for the services that we're billing out, you might find that some payers are automatically down coding you. For example, you might be billing a 99284 and they're paying you on a 99283. So it doesn't show up as a denial. The only way that you would really catch this is if you're performing that remittance advice review. And so that's another case to be made for understanding how you're being paid, what you're being paid, having some sort of a process in place to ensure that the payers are paying you as they should be for the services that you're providing and per the contract. If you're seeing that you have a payer that is down coding you, and this is a trend, a continual occurrence, it's it's worth your while to reach out to that payer and see if they will give you any feedback on what they're utilizing as their algorithm. That doesn't necessarily mean what they're doing is right, but at least you would have a sense of what they're looking for, and they may not share that with you. Again, sometimes they keep that information pretty close to the chest, and they may not be very transparent with what their algorithm looks like. But if they could give you any feedback whatsoever on, is it patient's acuity? Is it the diagnosis codes that were used? Sometimes they might be just driving it based on diagnosis codes that fall into that unspecified category versus a more specific diagnosis code, which then could speak to a documentation improvement opportunity with your emergency room providers. So there's some valuable information that can potentially be gained from having these conversations with the payers if you're finding that they're doing this to you. If they're downgrading you even more to like a level two, that's even more concerning because that's clearly going to impact your reimbursement, especially when you were expecting payment on like a level four or even a level five. So it would be worthwhile to have those conversations with the payers. And if it leads you to a compliance risk or compliance concern that you can address from that perspective, then that's just another way that you can mitigate risk in this space with the emergency department. So shifting gears a little bit, and this is a compliance topic simply because when we outsource any of our revenue cycle management services, there's a lot of contracts involved, there's agreements, there's language in those contracts that we need to pay close attention to. And as I was saying in the previous section of this presentation, it's ultimately your facility's name on the claim form. So whether you decide to outsource or keep revenue cycle services in-house, or maybe it's a combination of both, whatever it is that you have determined to outsource is still your responsibility to ensure that that work is being properly conducted. And so just to go through maybe a little bit of pros and cons, or maybe the reasons behind, I think it goes without saying that there could be some cost benefit to outsourcing revenue cycle staff. There's staffing shortages, perhaps, where you're just not able to get qualified candidates to work at the facility in the revenue cycle space. Or maybe it's a skilled staffing issue, and maybe with your staff shortages, you're not really able to train staff as you would like to. And so outsourcing might be an option that you've looked into. So these are just some reasons why healthcare organizations look at outsourcing. And also, they might be looking at outsourcing only parts of the revenue cycle. Maybe coding stays in-house, or maybe only coding is outsourced. So that's just an example of some of the directions that that might go. There's clearly some advantages to outsourcing. There's potential cost savings, and that comes in the form of overhead expenses, salaries, benefits, training. Also, there could be a cost savings from having to invest in technology and some of the expensive systems that might have to be purchased at the organization in order to have an efficient and effective revenue cycle management at the organization. The other thing that's an advantage with outsourcing is they can usually adjust pretty easily to any volume fluctuations at the organization. So they already have their staff, and they can adjust as needed and put more staff on you as their client, or remove staff if something changes from that perspective. So then it also frees up staff in your internal department to prioritize other areas that you might want staff to be working on. Maybe you decide that you want follow-up to remain in-house, and you have staff that are prioritizing follow-up and working denials. It also creates an opportunity for specialized professionals to work on the specific types of claims that they might specialize in, which creates efficiencies around accuracy and speed. So some of the disadvantages, though, that we would look at is this gives you limited ability to oversee the day-to-day billing operations. You really don't have as much hands-on insight into that because these are really not your staff, and you're trusting that the vendor that you've outsourced this to is going to take care of this and oversee it properly. There could be some data security concerns just depending on what this vendor's model is, if they're using overseas staff, What are the security concerns around that? And sometimes that's not even an overseas seas issue. Hacking can occur with any organization, regardless of whether they're 100% located in the United States or not. So I think that we've all experienced some of those types of situations in some form or fashion, either at our own organization or at least have heard about it at others. And then there's those communication challenges between the internal staff and the vendor staff, and that can lead to delays in issue resolution. I think one of the remedies to this would be ensuring that there is a strong liaison, someone from that vendor side that's assigned to you, the client, and they're your main point of contact for you to be able to address these issues and decrease the opportunity for delays here. One of the things that can be a challenge as well is that vendor's ability to tailor their practices to your organization's needs. And there really isn't a one size fits all approach to revenue cycle, but when you've created a partnership with a vendor, sometimes that's somewhat of the model that you might see. And so there could be some frustration there with their model might not align quite right with how your organization is set up. So when we think about keeping things in-house from a revenue cycle perspective, well, the clear advantage is going to be you're going to have control and oversight of every aspect of revenue cycle services. You're going to know who's working what, who's what the job designations are for each of the individuals, what their role is in that revenue cycle continuum. And if you need to make adjustments, you can make adjustments right then and there. They're all there as part of your organization, and there isn't that disconnect between you and what the vendor staff might be doing. So again, faster communication, issue resolution can happen in a much quicker way. It might be something that you address on a daily huddle, and it's addressed right then and there in that moment. You can maneuver your internal staff to align closely with the clinical workflows. Even if that clinical workflow changes, let's say you have an EHR upgrade or even a new EHR implementation, all of your internal staff can still remain and their jobs might shift a little bit, but you can make those decisions in real time as this happens at your organization and as you have more information and perform those analysis. And then you have that personalized billing support for your patients. So there isn't that disconnect between what they might be receiving from a billing perspective that the vendor sent out, and maybe you're not exactly sure what that looks like. You're better able to answer questions and explain to patients what might be occurring from that billing perspective since you all performed that in-house. And it does mitigate some risks with the external vendors. And I'll get into that in a moment. But some of the disadvantages is there might be some higher operational costs. It just depends on the agreement that you have with the vendor. Um, oh, I'm sorry. I meant to say from keeping in-house revenue cycle management, higher operational costs because of those salaries, benefits, and training. There could be some recruitment and retention challenges just because it's hard to find staff and retain staff in some of our communities. If you have the ability to grow your own, that's always a great option because not only does that provide jobs in your community, but it also gives these individuals a pathway to growth. But that again comes with the cost of time and an effort to put into those staff members and finding people that can train those individuals. Another disadvantage is it's difficult to stay updated on the ever-changing regulations in the CMS world with our MACs. It's time-consuming to read those newsletters and stay on top of those decisions. However, we'll talk about this a little bit at the end. This is something that we would want to do anyway. Even if we're outsourcing, we do need to know and understand the regulatory changes that are taking place and not just trust our outsourcing company to do that for us. There could be some technology investments that are required on your end when keeping it in-house. And then some adjustments to that volume changes. If you have staff that are cross-trained in your internal revenue cycle, then this can be mitigated pretty easily with with being able to shift staff around if there's a volume change. And again, that would require training and investment to ensure that staff is cross-trained to do some of this work. So again, there's there's a lot of advantages to creating the in-house environment or maintaining that in-house environment, especially from that oversight perspective, and also when it comes to aligning the organization's goals. When it comes to the risk side of things, I think that where where compliance comes in is we want to ensure that we're not blindly trusting the outsourced vendor to be staying up on regulatory requirements. And also, we might find that there might be some critical access hospital or RHC billing specific rules that we really need to ensure that whoever that vendor is, that they understand those things and that they have their systems built to accommodate some of the nuances around critical access and RHC billing. Sometimes that alone can be a bit of a challenge. So not only do we need to stay educated internally, regardless of what model we go with, but then we need to check and make sure that the vendor is essentially providing us with a quality work product. And the only way to really do that is to audit the vendor. And again, this is something that would take some time. It creates it's part of an auditing and monitoring program, but it would be no different than if you were performing this work in-house. We would want to take a sample of claims. Maybe it's once a month we pick 5 claims from a specific department, and we look to see, was everything billed out properly? And did we also have appropriate documentation to support what we build? And that's a good practice just to have in place, regardless of what model you choose to go with for your organization. But that's really one of the essential compliance components for compliance programming, which we talked about back in June. So ultimately, the organization needs to make the choice that fits them best. And some analysis would need to be performed, but just keep in mind that you would want to review those contracts and agreements very carefully and in detail and ensure that the expectations with that company align with your organization, but then you also need to hold them accountable to performing the work that they've agreed to perform and ensure that their understanding of those expectations. Also, if it's a partially outsourced arrangement, what are the expectations for the outsourcing company versus who is responsible internally for which tasks? And ensuring that that is documented properly and there is a clear communication between the organization and the vendor on who is responsible for what component of the revenue cycle. The last thing you want is duplication of efforts or for something to fall through the cracks, thinking that it's going to be performed and then it ultimately is not performed as you thought it would be. So the final piece here, and I know this is very specific, but this is something that has definitely gained a bit of traction over the last few years, and that's financial assistance policies. So this is a regulation under the Affordable Care Act, actually, and it applies to nonprofit hospitals. And it mandates that hospitals have a clear financial assistance policy that limits what they charge eligible patients and ensures fair collection practices. So this is just an overview of the requirements. Like I said, it applies to nonprofit hospitals under the ACA, requires hospitals to have a financial assistance policy, limits charges for these eligible patients. It prohibits aggressive collection actions, and it mandates public disclosure and accessibility. So, by adhering to this policy, hospitals not only remain compliant with IRS regulations, but they also fulfill the mission as a nonprofit organization to provide equitable care, support their communities, and maintain transparency with their financial practices. So that's really what the goals are around the financial assistance policy. So the policy process should include an application, and it should be a simple and accessible application form. The required documentation that the patient should provide should be outlined clearly in that application process. It should be available in a multitude of ways to the patient, online, in person, by request. And then there's the public disclosure component to this, where that policy must be posted online on your website. There should be notices provided in the hospital, both at registration and clinical areas. And it also needs to be available in multiple language. The goal here is that the process should be straightforward. There should be clear instructions. The application process should be easy and be available in multiple formats, depending what the patient might need. You want to widely publicize the financial assistance policy so that patients are clearly informed, they're aware of the various channels, and that they can easily access this information. And then those additional components around limitation of charges, aggressive collection actions, that should all be outlined in your policy, as I mentioned on the previous slide. So some best practices here is you want to maintain compliance through review of the policy. You want to train your staff on the financial assistance policy requirements so that they're communicating this with the patients. And then you want to ensure transparency with communicating assistance options to patients. So having a compliant financial assistance policy is critical to the hospital and the organization to maintain their tax exempt status. And they should be continuously educating staff, ensuring public awareness, and reviewing this policy for compliance. There's actually a little bit of a checklist that you can develop internally to monitor compliance. This would be a great addition to a compliance work plan because it wouldn't necessarily be very time consuming. It could be something that you review on an annual basis to ensure that you're meeting those requirements for your financial assistance policy practices. And if there's anything that changes from a workflow or a process perspective internally at the organization, then you're updating your policy as it should be to align with what's actually taking place and occurring at the organization. Again, this is not just compliance with the ACA, but this is also compliance with the IRS regulations. So there is quite a bit of scrutiny around this. And however, from an auditing and monitoring perspective, this is probably a little bit of a lighter lift than say performing chart reviews or auditing your outsourcing vendor for accurate billing and coding practices and those types of things. Some of those auditing and monitoring activities can be a little bit labor intensive and others not as much. So in the couple of minutes that we have left here, I just wanted to leave you with some final thoughts from a compliance perspective. It's very important that we sign up for our newsletters from CMS and from the MAC to keep up to date on current guidance. The only way to know about changes related to telehealth, coding and billing, or the financial assistance policy, for example, is to remain educated. And I know that there is a lot that comes through on a daily basis, but if you could identify two or more individuals that are responsible for receiving this information and then relaying that information to the appropriate individuals at the organization. Not everyone needs to know every regulation that's out there. I mean, that would be humanly impossible. But if there's something that relates specifically to E&M coding, well, then let's share that with those departments that it affects. We wouldn't necessarily need to share that information with radiology, for example. So, and then it doesn't hurt to also communicate this information to your vendor. We don't want to make the assumption that they are receiving the same information or that they're interpreting that information the same way that we are. If it's something that's very specific to, let's say, method 2 billing for a critical access hospital, this might not be something that your vendor is as comfortable with or as knowledgeable around as maybe you are, since this isn't something that they might deal with on a day-to-day basis. So it's always good to collaborate with your vendor, share information, and ensuring and receive a comfort level that they are aware and also in alignment with how you view the regulation. Developing an auditing and monitoring program around a variety of compliance topics, not just necessarily the things that we talked about today. You might have some very specific monitoring programs that you need in place for your organization that another organization may not need. These are just some things that kind of bubbled to the top with some of the work we do here. And so that's why I added them to the presentation today. But once we create that auditing and monitoring program as part of our compliance program, then we can start ensuring that we know what's happening in our organization, we know where our risks lie, And it can also validate that you're doing things correctly and that maybe you don't need to focus on a certain area as much as you need to focus on another. Resources are limited, and we want to ensure that we're focusing on the highest priority areas versus trying to boil the ocean. You might need to create some external partnerships for auditing and monitoring so that you can maintain this function at your organization. So look at your internal resources, and if there's things that pose a risk to your organization, might need to find that external partner that can just supplement your compliance program and help you out with some of these auditing and monitoring activities on an as-needed basis. So it looks like I'm out of time. But I hope that you found some of this information helpful. If there's anything that you would like to discuss or follow up with, my email address is right here. So that'd be perfectly fine if you would like to reach out via email with any questions.
Thank you, Rachel. I do want to, before everyone leaves, drop a couple of links into the chat and launch the poll. And then we do have a couple of questions, Rachel. So if you give me a moment, this poll, perfect, it is launched now. Let me look over into the chat. So we had a question and it was answered by one of the other attendees, but the question is, are there any good resources to help facilities determine the E&M level? There are times we believe it should be a level 4, but the insurances are denying of course. And do you see this?
Yeah, so I can't see the chat just because of the way my screens are set up right now. So maybe this is what someone answered. There's one resource out there. The American College of Emergency Physicians published a facility leveling tool on their website. There's no cost to take a look at that tool. And I want to say this was developed a good number of years ago. I don't know how often they look at it and update it. The one thing I will mention with their tool and just to be aware of is there are a couple of things within their tool that are noted that you would include in your level or consider in your level, I should say. But we're also going to be billing separately for those things. So, like for an infusion or an injection, for example. So there's just some, I'll just kind of leave it there as a word of caution that we typically don't want to assign points or consider the leveling for services that we're also going to be billing separately for.
Okay,
So
and
that's one thing I'll mention.
perfect. And she did comment that that is what they use. However, no, I'm sorry. Someone else commented, yeah, she stated that the insurance companies are asking them to use emergency department claim analyzer tool, EDC tool.
Can you say that again? Sorry, I didn't hear all of that.
Um, she commented that the insurance companies are asking them to use the emergency department claim analyzer tool.
I'm not familiar. What do you mean by the emergency claim analyzer tool? Is that something the insurance company is using?
That's something she said, they were told by the insurance company to use that tool.
Okay. I'll be honest, I'm not aware of that tool unless that's something that CMS has built on their website.
Um, and
I
then
can I can look into that more.
that sounds great. And then the only other question, yeah, she said that it's just a tool that insurance companies use. Um,
Oh, okay.
the only other question I see, Rachel, came to me directly, and it says, how can the board support this information at the governance level?
So going back to the session that we had in June, one of the things that we mentioned is board involvement and board support for the compliance function. And on the OIG website, there's actually a toolkit, and I think it's in those slides as well. I think I have the link there. There's a toolkit that outlines the board responsibilities for the compliance program. And so that's really the first step. in bringing the board into the compliance function. And if you have a compliance committee, which doesn't need to be a large number of people, but leadership at the organization, one thing to do is bring a board member into the compliance committee, and that individual not only has more of a direct lens on the compliance functions at the organization, but they can also be a liaison back to the board and can communicate the importance of compliance as well as share the compliance activities that are taking place at the organization. So that's really the starting point to bringing them into the governance side as well as supporting the compliance function. I don't know if that fully answered the question, but I'm happy to receive an email and follow up.
That sounds great. If we get any follow-up comments, I would be happy to pass those along.
Okay.
I don't see any other questions in the chat. Someone did ask if the previous two sessions are available to watch, and they are. We will send a follow-up email with the recording and the slides for this webinar, and we'll also link those first two webinars, so you'll get that in a couple of days. But if there are no other questions or comments, I think we'll go ahead and adjourn. Thank you, Rachel. That was an excellent presentation. And as always, we love having you on. Thank you, everyone, for attending. And I hope that we see you again next month.
Thanks, everyone.
Bye.